I want to welcome a special guest for our podcast for the Vein and Lymphatic University Voices newsletter. Dr. Nicole Keith is an interventional radiologist working at the University of North Carolina in Chapel Hill. She's one of the rising stars in interventional radiology and has been involved with some really exciting research. Dr. Keith is also an editorial board member for the VLU Voices newsletter. So Dr. Keith, some of the stuff that you've been working on has been looking at pregnancy and radiation safety. So what are some of the general risks associated with radiation exposure in pregnancy, and how can we appropriately protect our patients?
Risks during pregnancy, I kind of categorized into three different stages of pregnancy. The first being in the early conception stage from 0 to 8 days. In the pre-implantation part, if they get a dose, if a patient experiences a dose less than 100 milligrams, somewhere between 50 to 100, that can cause a spontaneous abortion. And in the post-implantation stage, that can also lead to an abortion, but it has to be at 250 milligrams, so a much higher dose. Then we think about the category of organogenesis, and that's anywhere from 8 days all the way up to 15 weeks. And those can be growth defects, growth retardation, small head size, mental retardation, reduced IQ, a whole bunch of different things related to that. And the incidence of those, though there's no true threshold, they say somewhere around 100 milligrams increases your risk of developing any of those things. And the last category is related to the stochastic effects, and that is there's no threshold that increases during any time throughout pregnancy, and that's predominantly the risk of childhood cancer. Most often we think about leukemia. In the first trimester, there's an increased risk of 25% per gray that a patient's exposed to. And later on, that risk is much, much lower. In the second and third trimesters, it's 6% per gray. So again, very low. But when we are radiating over the pelvis, particularly in venous disease, it does come into play. When it comes to protecting patients, in the same way that it comes to protecting yourself or any other non-pregnant patient, using the simple things of decreasing your pulse rate, coning in, collimating, reducing magnifications, not using DSA unless you need to, but also particularly in this patient setting, you can use IVUS as a supplement as much as possible, and minimizing the amount of radiation, obviously, over any sort of fetal area in order to minimize the risk to the actual baby.
Excellent points that I think we can take away for radiation safety in general also, but especially so with the pregnant patient. So for pregnancy-related DVT, what's the anticoagulant that you preferentially use?
Good question. The best anticoagulant approved during pregnancy is either heparin, fractionated heparin in the inpatient setting, or if they're going home, low molecular weight heparin. Both of those are safe and preferred during pregnancy. For patients who have HITs, fondaparinux is a good alternative. DOACs and warfarin are both contraindicated in pregnancy, so neither one of those should be used at any point during pregnancy. I would also avoid them in the patient that is trying to get pregnant, because you never know during that early stage when actual conception occurs.
So if you had a patient who is pregnant and has a DVT, would you go ahead and perform a thrombectomy or thrombolysis?
I think it's really dependent on the patient's presenting symptoms, the stage of gestational age, as well as the provider experience. TPA was historically contraindicated in pregnancy, but there have been case reports as well as articles within prominent journals such as Stroke and from the American Heart Association about the use of TPA with good maternal results afterwards. It's also too large to cross the placental barrier. So there's no concern, at least based on those articles, about risk to the actual fetus. It's more the risk of hemorrhage from the placenta or from the uterus. I think if a provider is comfortable using just mechanical thrombectomy, that would probably be my preference, because then you negate any risk even though we don't know about it, but it's really provider dependent.
So would you recommend stenting a May-Thurner lesion during pregnancy?
I would not, because there's so many venous changes that occur during pregnancy. You have so much increased blood volume that your veins can dilate, and so you can easily missize a stent during pregnancy. I think if you can get rid of the acute clot in order to prevent long-term post-thrombotic syndrome, then you can come back at a later date and evaluate if they warrant stenting based on IVUS.
So if you did the thrombectomy and you saw a May-Thurner lesion, would you try to balloon it or would you just leave it?
I'd still balloon it, but you balloon it, you put them on some long-term Lovenox during the remainder of the pregnancy, and bring them back a month or two postpartum to reevaluate things and potentially stent at that point.
I actually think that's an important point that you brought up, that you would wait at least a month or two postpartum just to get over the peripartum hypercoagulable
Mhm.
state with antithrombin 3 deficiencies, et cetera, that can last for a couple of weeks after postpartum. So that's actually quite important to wait and let things settle down. So during the procedure, what's the best way to appropriately position the patient?
It's tough, and we've learned a lot of things through COVID, actually. As you can imagine, pregnant women got COVID and actually had a higher rate of having more severe COVID. So we have experience with pregnant patients now. And so pregnant patients can be proned just with appropriate supporting pillows so that you're not pushing on the gravid uterus. And actually, it does result in less compression upon the veins that you're working in. If for whatever reason you can't do that, then they can be in a left lateral decubitus is the next ideal position if you're choosing to go through the popliteal veins.
And an important question during the procedure, when would you use fetal monitoring?
Fetal monitoring is recommended intraprocedurally if the fetus is viable, meaning 22 weeks. And because prior to that, if something were to happen during the procedure such that the fetus, the heartbeat stops, they can't come back from that. Whereas if you have a close relationship with your OBGYN colleagues, and at 22 weeks, if something were to happen and they can continue monitoring during the procedure, they have to be prepared for an emergency C-section. And you have to have that extensive, challenging conversation with the patient ahead of time that those are the risks. And just fetal monitoring is not enough. You can't just have some OB nurse come down and watch the patient and the baby for you. They need to be prepared to intervene should, the worst case scenario occur. Prior to 22 weeks, it's reasonable to check a fetal pulse beforehand and a fetal pulse post-procedure, but intra-procedural monitoring is not warranted.
That actually highlights an important point with multidisciplinary care in these patients because without that, I don't think you end up with the best results. And so again, working with your OBGYN team, your anesthesia team, et cetera, because there's so many other things that are going on, we really need to take all of those points into consideration.
The one
So
last thing
thank
I
you.
want to bring up before we go is just the breastfeeding patient, because a lot of people don't think about this, that with normal contrast, you don't need to pump and dump. ACR does not recommend it, or at least it's optional. And that there's increased radiation risk to the breast tissue during breastfeeding. So if possible, routine imaging over the chest should be avoided until the patient is done breastfeeding, just because of that risk.
Thank you very much for this interesting podcast. And I think it'll really help some of our listeners and some of our readers. And looking forward to more talks with Dr.